Professor Chan is the faculty of University of Malaya, Kuala Lumpur, Malaysia, for which that's we'll give the first talk, then Professor Saren will give the second part of talk. Due to limited time, I wouldn't go through any details about the introduction. I think all these professors are renowned in the fields of hepatology and in this region or even in the world. And now, Professor Chen, please.
Thank you very much, Mr. Chairperson, for your very kind introduction. Good afternoon, ladies and gentlemen. It is really a pleasure for me to be here today at the APASL STC on liver fibrosis in the era of translational medicine. Over the next 20 minutes, I'll be speaking on transient elastography in MAFLD beyond diagnosis of liver fibrosis. This is the outline of my talk, and we will start by looking at liver stiffness measurement for the diagnosis of liver fibrosis and how this has evolved into a risk stratification strategy by combining with fibrosis score, and how this forms the backbone for clear assessment and referral pathway for MAFLD. This slide shows you one of our earlier work where we look at 101 NAFLD patients who underwent liver biopsy and transient elastography on the same day. As you can see here, the liver stiffness measurement increased accordingly with increasing fibrosis stage, and we found that liver stiffness measurement was excellent for the diagnosis of advanced liver fibrosis with an AURC of 0.93. This table shows you the sensitivity and specificity of liver stiffness measurement for the diagnosis of the different fibrosis stages using the optimal cutoff that was proposed by Professor Yoneda and colleagues at that time. 8 kilopascal was used as the cutoff for diagnosis of advanced liver fibrosis during that time. Our subsequent work looked at the NAFLD fibrosis score and liver stiffness measurement either alone or in combination for the diagnosis of advanced liver fibrosis. As we know, the NAFLD fibrosis score may be indeterminate in a significant proportion of patients. In our study, we found that 30% of patients had indeterminate NAFLD fibrosis score and may require a liver biopsy for the diagnosis of their fibrosis stage. On the other hand, liver stiffness measurement was associated with misclassification in a significant proportion of patients. This was because of the false positive rate of diagnosis of advanced liver fibrosis using the 8 kilopascal cutoff for liver stiffness measurement. Surprisingly, when we used both tests for all patients, we found that an even higher proportion of patients required liver biopsy. This was largely due to the discordant result among patients who had low NAFLD fibrosis score, but at the same time had liver stiffness measurement more than 8 kilopascal. On the other hand, when we use a two-step approach where only patients with indeterminate or high NAFLD fibrosis score were subjected to liver stiffness measurement, we found that the proportion of patients who had indeterminate or discordant result was significantly reduced, but at the same time, the misclassification rate was maintained. This has led us to propose the two-step approach, and using this approach, only about 1/3 of patients would require a referral for liver stiffness measurement. This slide shows you the two-step approach where patients with low NAFLD fibrosis score will be considered as not having advanced liver fibrosis, while patients with indeterminate or high NAFLD fibrosis score will be subjected to liver stiffness measurement for the diagnosis of advanced liver fibrosis. The two-step approach was refined and validated in this subsequent work using data from the Go Asia cohort. First of all, we found that the fibrosis 4 score provided similar accuracy as the NAFLD fibrosis score for this purpose, and we preferred the fibrosis 4 score because it requires less variable and is easier to use. Secondly, we found that using the 10 and 15 kilopascal cutoff was better compared with the 8 and 17 kilopascal cutoff. One of the main challenges of tackling NAFLD or MAFLD is the very high prevalence of the disease in the general population, but only a small yet significant proportion of patients had advanced liver disease. In this study by Professor Vincent Wong and colleagues in Hong Kong, you can see that the prevalence of NAFLD was 27%, while the prevalence of advanced liver fibrosis was only 3%. So how do we identify those patients who has more advanced liver disease and require specialist care? In this study using data from the Go Asia cohort, where we included 1,008 biopsy-proven NAFLD patients, we found that a risk factor for NASH included a high BMI, diabetes mellitus, dyslipidemia, elevated ALT and AST levels, while risk factor for advanced liver fibrosis included increased age, diabetes mellitus, and a low platelet count. In other words, diabetes mellitus is an important risk factor for more severe NAFLD. In this other study from our center, where we use transient elastography on patients who attended the diabetes clinic in our center, we found that a large proportion of patients had NAFLD, and over 20% of the patients had advanced liver fibrosis. And among those patients with liver stiffness measurement more than 8 kilopascal who were referred for further assessment and underwent liver biopsy, we found that the majority of them had NASH and some degree of fibrosis, and over 1/3 of these patients had histological advanced fibrosis. In other words, a patient with type 2 diabetes mellitus represent an important target group to identify more severe MAFLD. That is why we have included a clear assessment and referral pathway for NAFLD in patients with type 2 diabetes mellitus in the latest guideline for management of type 2 diabetes mellitus here in Malaysia. You can access this guideline using the QR code shown here. In the guideline, we use simple blood tests, namely the liver function test and the full blood count for liver assessment in patients with type 2 diabetes mellitus. I would like to draw your attention that we use the fibrosis 4 score and recommends that patient be referred for liver stiffness measurement if the fibrosis 4 score is increased. The guideline also provides interpretation of liver stiffness measurement, where patients with liver stiffness measurement less than 10 kilopascal were considered unlikely to have advanced liver fibrosis, and the negative predictive value of this is over 93%. Patients with liver stiffness measurement between 10 to 15 kilopascal may have advanced liver fibrosis and requires monitoring, while those with liver stiffness measurement more than 15 kilopascal are considered likely to have advanced liver fibrosis and should be considered for liver cancer surveillance. The positive predictive value of this for diagnosis of cirrhosis is more than 86%. Patients with liver stiffness measurement between 20 to 25 kilopascal, especially in the presence of thrombocytopenia, are likely to have clinically significant portal hypertension, and they should be considered for liver cancer surveillance and varicose screening. These patients should be referred to the gastroenterologist or hepatologist for further evaluation and management. The Baveno group has proposed the term compensated advanced chronic liver disease to reflect that the spectrum of severe fibrosis and cirrhosis is a continuum in asymptomatic patient, and that distinguishing between the two is often not possible on clinical ground. The 10 and 15 kilopascal cutoffs have been similarly used for the purpose of diagnosis of compensated advanced chronic liver disease. Next, we'll take a closer look at how liver stiffness measurement can be used for diagnosis of clinically significant portal hypertension. A hepatic venous pressure gradient of more than 10 mm mercury is consistent with clinically significant portal hypertension, where varices start to form, while hepatic venous pressure gradient more than 12 mm mercury is consistent with severe portal hypertension, where there's a higher risk of variceal bleeding as well as a formation of ascites. As mentioned earlier, a liver stiffness measurement more than 20 to 25 kilopascal, especially in the presence of thrombocytopenia, is sufficient to rule in clinically significant portal hypertension. On the other hand, patients with liver stiffness measurement less than 20 kilopascal and a normal platelet count has very low risk of having varices that require treatment and can avoid screening endoscopy. This patient can be followed up yearly by transient elastography and platelet count. Liver stiffness measurement is also very useful for prognostication. Liver stiffness measurement has been shown to be predictive of overall survival in patients with chronic liver disease, including MAFLD. In fact, liver stiffness measurement may be better than histology by being able to further stratify patients based on increasing value of liver stiffness. In this study by Professor Busio and colleague on more than 500 NAFLD patients who were followed up for a median of 6 years, liver stiffness measurement was found to be predictive of overall survival and survival free of deaths from liver-related complication. As you can see here, the higher the liver stiffness measurement, the worse the overall survival, and the lower the survival free of death from liver-related complications. This is the experience from our own center where we followed 202 NAFLD patients who had baseline liver biopsy for a median of 7 years. We recorded 5 liver-related events. 1 patient developed liver cancer and ascites, 1 patient had bleeding esophageal varices, and 3 patients were diagnosed with esophageal varices during screening endoscopy. 4 of these patients had histological F3 fibrosis, while 1 patient had cirrhosis at baseline. Liver stiffness measurement at baseline range between 11 to 26 kilopascal. What I would like to emphasize here is that histological advanced fibrosis and liver stiffness measurement had similar accuracy in predicting liver-related events. Transient elastography is also very useful for diagnosis of hepatic steatosis. Attenuation parameter is the decrease in amplitude of ultrasound as it is propagated through the liver tissue, and this can be estimated using the same radiofrequency data that are used for estimation of liver stiffness during transient elastography examination. We have previously shown that attenuation parameter is excellent for the diagnosis of hepatic steatosis. However, its accuracy is impaired by an increased BMI, and it is less accurate to distinguish between the different grades of hepatic steatosis. You can see here the attenuation parameter is significantly different among patients who have significant hepatic steatosis compared to controls who did not. And when we look at patients who were non-obese, you can see a significant difference in the attenuation parameter among patients who had different grade of steatosis, but this was less so among obese patients. In a subsequent individual patient data meta-analysis, the optimal cutoff for identifying the different grades of hepatic steatosis were identified, and these were 248 decibel per meter, 268 decibel per meter, and 280 decibel per meter respectively. It was also found that BMI, diabetes, and etiology had significant influence on attenuation parameter, and it was recommended that adjustment be made for this in interpretation of attenuation parameter. Transient elastography provides a simple and convenient way to diagnose hepatic steatosis among patients with chronic liver disease who are undergoing the procedure anyway for liver stiffness measurement to assess liver fibrosis. This is very important, as can be seen in this study that we have just concluded, whereby we found that a high proportion of patients with chronic hepatitis B had significant hepatic steatosis. Furthermore, we found that presence of hepatic steatosis in patients with chronic hepatitis B was associated with significantly greater proportion of components of the metabolic syndrome, including obesity, central obesity, diabetes mellitus, hypertension, and dyslipidemia. Hepatic steatosis was also associated with worse markers of liver disease severity, including higher ALT, AST, and GGT, and higher liver stiffness measurement. Therefore, it is important for us to identify significant hepatic steatosis among patients with chronic liver disease who are undergoing transient elastography so that the significant hepatic steatosis can be addressed accordingly, and hopefully this will help reduce metabolic risks as well as severity of liver disease in the long term. Next, I would like to show you some data from a study that we have performed comparing 2 transient elastography devices, namely the FibroScan and the FibroTouch. In this study, we performed over 1,300 examinations on 167 patients with chronic liver disease of various etiology. And we found that the attenuation parameter and liver stiffness measurement from both devices were strongly correlated with each other. We did notice that the attenuation parameter and liver stiffness measurement obtained using FibroTouch was slightly higher in the lower extreme of measurement and slightly lower at the higher extreme of measurement. However, measurements in the mid-range were really very similar using both the devices. The FibroTouch does have the advantage of using a universal probe, and we also found that it has significantly lower IQR for attenuation parameter and IQR median for liver stiffness measurement. We also found a shorter examination time as well as less invalid measurement with the FibroTouch compared with the FibroScan. In this other study on 237 NAFLD patients who underwent liver biopsy and FibroTouch, the optimal cutoff for attenuation parameter for diagnosis of significant hepatic steatosis was determined to be 244 decibel per meter, while the optimal cutoff for liver stiffness measurement for diagnosis of advanced liver fibrosis was determined to be 9.4 kilopascal. These cutoffs are actually quite similar to the cutoff that we have heard earlier, which were derived for the FibroScan, and this is also consistent with our observation that the measurements of attenuation parameter and liver stiffness using both devices are strongly correlated with each other, and that the measurements were similar in the mid-range of measurements using both devices. There may also be a role for diagnosis of NASH using transient elastography. In this study on 259 NAFLD patients who underwent liver biopsy and FibroTouch, where definite NASH was defined as the presence of hepatic steatosis, lobular inflammation, and hepatocyte ballooning, and a NAFLD activity score of at least 5, 2 out of 18 ultrasonographic features, namely P7 and P13, which was associated with intensity and scattering of ultrasonographic waves respectively, were found to be significantly associated with definite NASH and were used to calculate the QUS score. The QUS score was found to have a fair to good diagnostic accuracy for definite NASH in both the training and validation cohort. Using a QUS score cutoff of 6 and 7.5 provided a good sensitivity and specificity for the diagnosis of definite NASH. However, a significant proportion of patients has indeterminate score between 6 and 7.5, and further studies are needed to improve our ability to diagnose NASH using non-invasive tests. Lastly, transient elastography can be used for epidemiological studies on MAFLD. For example, the FibroTouch FT100 device is a very portable machine, and this machine has been used, for example, in this community-based study with multi-stage stratified cluster sampling in Beijing, where more than 70,000 participants aged more than 25 years old were included, and the prevalence of MAFLD in this study was found to be 32%. We had similar experience using the same device for a study on MAFLD and advanced liver fibrosis among end-stage renal disease patients who were on hemodialysis. So the device was brought to the different dialysis center here in Klang Valley. We found the prevalence of MAFLD to be 43% and advanced liver fibrosis to be 25%. With that, Mr. Chairperson, ladies and gentlemen, I'd like to conclude by saying that transient elastography is a very useful non-invasive tool for the diagnosis of liver fibrosis in MAFLD patients. It forms an important part of a simple assessment and referral pathway for identifying patients with more severe MAFLD. Its use can be further expanded for evaluation of clinically significant portal hypertension and for prognostication purpose. Furthermore, it can simultaneously assess for hepatic steatosis when using for liver stiffness measurement for other chronic liver diseases. Last but not least, portable devices is very useful for epidemiological study.